Welcome to the 2014 training for care coordinators. This training is made possible through a grant through the Illinois Department on Aging. Today we're going to do the training through the telling of a couple of stories. And these stories are of actual participants that our care coordinators have been involved with. In the first scenario, we have an individual who is having difficulty with decision making due to her confusion. In the second story, we have a gentleman who has been diagnosed with Alzheimer's disease, but he is exhibiting some challenging behaviors which may make it difficult for him to continue to receive in-home services. We will be telling the story through the eyes of a new care coordinator, staffing it with her supervisor, through an experienced care coordinator, staffing with a supervisor, and then using the expertise of our panel of experts. On this panel, we have representatives from SIU School of Medicine, through Northwestern University, and through Rush Medical Center. We hope that through the telling of these stories that you will garner some tips and options that you may use when you encounter these challenging experiences. In our first scenario, we have the story of Mrs. K. Mrs. K's referral was called into the Illinois Department on Aging Senior Helpline by an Ameren, which is a utility company, a representative, who went out to visit Mrs. K because she had an outstanding bill of over $1,800. In previous attempts, she didn't seem to understand that her bill had gotten that high. So he did a home visit. He found her to be confused, and when he asked her about the bill, she thought it was paid. He tried to give her some additional information about other help for utilities, and she had a lot of difficulty writing the information down. She also seemed very depressed, and when she made a statement that said she wished that the good Lord would just take her off this earth. He asked her point blank if she was suicidal, and she said no, the Lord wouldn't like it if she killed herself. But because of his concern about depression and confusion, he made a referral to the Department on Aging, which was then given to a local care coordination unit. We'll now listen to care coordinator Ria, who is a new care coordinator staffing this case with Supervisor Waivana.
So I received the referral and I called Mrs. K, and it took her a while to get to the phone, but then she said that she was doing fine and she didn't really feel like I needed to come. So I explained the referral and why that they had called us and that they were concerned about our utility bill. But she said she didn't think she was behind at all, and she was surprised about that. I asked her also about the statements she had made that the referral source was concerned about her being suicidal, but she said, oh no, she would never do anything like that, and she had a strong faith and would never harm herself. So I asked her if there was anyone else paying her bills, and she said her son came by every 2 weeks and paid the bills. And I asked her about her income, if there was anything else to support her Social Security to help pay this high utility bill. And she said she owned some properties, but she couldn't tell me any specifics about that at all. So she did give me verbal permission to call her son, and I called and left several messages for him, but he never returned my calls. So my question is, even though she's saying she's doing fine, she's still not wanting me to come. And also, how often do I need to call the son, even though he doesn't call me back? I don't want to seem like I'm harassing these people. What do you think?
Well, I think there's a couple things that we could do in this situation. One, I would like for you to continue to call Mrs. K just to check in with her. Secondly, let's send a letter to the house. Because the son comes over every 2 weeks, maybe he'll get the letter and then he'll return your call. And third, let's try pairing you up with the more seasoned care coordinator so that you guys can go out and look at the situation with 2 sets of eyes.
Okay, that's a good idea.
So since this was a self-neglect referral, Ria and I had gone out to see Mrs. K. We made an unannounced visit. She was pretty warm and receptive. She allowed us to come into her home. The entryway was pretty cluttered. There were about 6 steps leading up into her home and then 6 steps leading down into the basement where she had her washer and dryer for her laundry. We walked up into the kitchen area. Her table was set pretty nicely. She had a vase with plastic flowers, but the countertops were covered in bags, boxes of food, cans of food, and you could hear rustling in and out of the boxes and in and out of the stove. Every now and then you'd see a mouse pop up. She allowed me to contact Ameren, but when we called using her telephone, we found that her line had been disconnected, so we called using the agency cell phone. When I got in contact with Ameren, they said the bill was now up to over $1,800, and they gave me some locations in the area where we could drop off the payment. Mrs. K was pretty shocked that it had gotten up so high, but she was willing to make the payment. We were unfortunately not able to find her checkbook. We went into the bedroom to look for her purse, and there I noticed that her bed was piled about 3 feet high with clothing. She said that she typically sleeps on the couch in the living room since it's so full in her bedroom, but she didn't really seem too concerned about any of the clutter. Once we decided that we couldn't find the checkbook, we completed an assessment. She allowed me to do so. She had admitted that she gets pretty depressed. She said her son doesn't visit her very often. She became pretty tearful. She got a little upset. We completed the depression and suicide addendums. Okay. She doesn't have any plans. She's never had any previous suicide attempts. And she's never had any kind of psychiatric hospitalization of any kind. She also said that she's a member of the Jehovah's Witness Church and her faith is pretty important to her. So she would never hurt herself just because of that faith. Her express goals were, I want to stay in my own home as long as possible. I want to die because I'm so lonely and not able to do things for myself. Her DON at that time was a 36 with an MMSE of 25. We talked about doing the emergency response button since her laundry is down in the basement. She lives by herself and doesn't have a lot of people checking up on her, and she gets a little bit confused at times. I thought that might be a good option for her safety, but it wasn't something she wanted to consider at this time. Her DON had gone up to 52 at this assessment, and her MMSE had dropped to 19. And it was a pretty significant difference from when we saw her 3 months before. She did say that she wanted me to continue to come back because she trusts me and she really enjoys having our little visits. Afterwards, I did attempt to contact both her son and her sister on 3 separate occasions without any luck getting in touch with either one of them. So what's my next step from here? I can't really keep going out, helping her pay her bills every month. And she's continuing to get worse, both physically and mentally, but isn't really willing to make any changes.
I think you and Rhea have done some excellent work. I think you guys have really made an impact on this lady. Unfortunately, I would like to continue to go see her. However, I think we should get some extra support in. Maybe we should call for some assistance from the Alzheimer's Assistance Center to help us get an expert view on how to handle this client.
Thanks for coming to join me today. As you know, I sent you information on this very interesting case and difficult case, and just glad that we could all get together and discuss what we can do for this lady. This was from the case community case coordinators.
Yes, I was very impressed looking at the report that you sent, the lengths that the case coordinator went to build a trusting relationship with this client, and her attempts to getting a medical evaluation as well. So I'm just really questioning, though, this individual's capacity to make decisions for herself.
Yeah, and I thought that was really a big piece about this case, is that sort of early prioritization around the fact that there's sort of this disconnect in the story. Mm-hmm. So even if you take the example of the mini-mental score of being 25 out of 30, which seems relatively good in many cases, there were too many other clues going on even early that something was not right. The person was having difficulties making judgment decisions, handling their finances, having a large bill build up for their gas utilities, and not being able to really locate or find things to make sure that she can really take care of herself. And I think sort of that early evaluation, that trigger should be not just depending on the mini-mental score, right, and saying the mini-mental score is pretty high so that the person has the judgment and capacity, but it's to really question that and to say, I'm seeing all these things that are making me uncomfortable, that the person is having confusion and judgment problems, and they need to seek advice. And usually that's, the starting point is the medical team. But it sounds like there was quite a bit of difficulties in getting those services for the person, Mrs. K, to feel comfortable to go to her prior doctor, even though that doctor might not have seen them for 20 years. And I'm just wondering if there was any other way that we could almost think about the medical capacity or that evaluation coming to her, and what would be the possibilities there.
It sounded like the coordinator had made very good rapport with the patient, so perhaps she could bring in like a private geriatric caseworker who could maybe segue into some other services for her and get her to medical attention, or have a home physician come if the patient would be willing to do that. Sounded like she didn't get out as much as she used to, so maybe having someone come to the home to evaluate her or do an assessment, if there are people like that.
I think that both the son and the sister, they sounds like they were doing the best they could within their own limitations. But one of the limitations I think that exists is that they're not really clear as to what's wrong with their mother, their sister. So, I mean, they, again, going back to that medical evaluation being really essential to help frame what is it that's wrong with her,
Right.
and then taking those next steps.
So if she hasn't had a medical evaluation, we don't know for sure that it's dementia. I guess I'll let you speak to that.
Yeah, so I think that there are probably other things we have to think about, especially in this history where we've got a story that even over 3 months she changes on her score from 25 to 19, even though she was getting more help and services. It does make me wonder if other things that might be going on here, whether be an exacerbation of her mood and her depression that's making things worse for her, whether she has other medical conditions because she hasn't seen a doctor for 20 years that might be brewing and causing her to have more memory difficulties. Even simple things as the kitchen wasn't well kept, and we're not really sure exactly what she was doing as far as her eating and her food habits. If she went low on her vitamin B12 levels because she's not eating well, those things can affect memories. Many people have thyroid difficulties and hypothyroidism or low thyroid function that can develop over many years slowly, and a simple blood test would just even help us to get there. But it's how do we get somebody to come in that home that can start that medical evaluation process. And I know we have a list of people that might specialize in sort of in our communities and areas that might want to work with individuals that have dementia. And that's something maybe we can share with the case coordination unit, so they have a plan B when their initial attack with the engagement to try to get the primary care office to engage with her wasn't really working, that there would be better things we could offer or suggest another way of getting a doctor to come in to do an evaluation.
And making sure that the family maybe gets more involved, if possible, make sure they understand her illness, that it's not her acting out to them. It sounded like she had a different personality prior to getting this dementia, that she and her sister used to go to lunch every day, and now that she distrusts the sister and hides her checkbook from the sister. So educating the sister and the son as to how this dementia or whatever is going on with her is affecting her judgment.
And how do you think we could do that, Darby? I mean, there might be some things through the Alzheimer's Association that might be helpful to the family members.
Yeah, well, they could certainly go to the Alzheimer's Association. They have care consultants, and they could sit down with a social worker and really talk with them in depth about what they're seeing, and that, again, that could help to mobilize some resources similar to the case manager. But there's also a number of different support groups throughout the state of Illinois, and going to a support group and hearing how other people are, handling the care of their loved one who is having changes and living alone and increasingly more vulnerable.
Yeah, and especially when the sister said, I mean, in her comments, just off the cuff, that she thinks, her sister, Mrs. Kay has troubles with memory and that she thinks are due to Alzheimer's disease. So she already feels something is not right. And she
Exactly.
just needs to know then what that means when she says somebody has Alzheimer's disease and what sort of the responsibilities are for the family sometimes to have to step in and help to kind of advocate for the person to get the needed services, because they may be resistant. They may not see that they're having these problems. And how do we make sure, say they get, she gets hospitalized or has to go to the emergency room, that they can advocate for her while she's there to get an evaluation to make sure that everything is okay with the memory.
I agree. It's really crucial to engage this family in the care of Mrs. K. And there are a number of ways that we could do that that we're talking about here.
So hopefully in this situation, you would hope that you could engage the actual client first as the option to get medical care, to figure out what's going on and to make a decision about her capacity. If you can't do that, your option 2 is to try to work with the family and get their buy-in and advocacy to help make the situation happen. But if they can't meet those responsibilities, sometimes we have to think about other legal systems that can come into play that can answer these questions around who can provide the best care and support and advocacy. So it's more formalized. So it's not like the case manager who's did a remarkable job in keeping the relationship going feels like she's filling that role without really having the authority sometimes to be able to do all those things.
I think that one thing that we could, just clarify first is that Mrs. K has never given anybody a power of attorney. Is that right?
Yeah, I think you're right. That's what they said in the report.
Okay. So with that being said, I guess then there's that question now. Her capacity is so questionable about whether or not she'd even be able to give it to someone. We know she's not likely to give it to her sister since she has such, paranoid thoughts about her. And, and at this point, again, even if she were to give it to the son, it's not clear that she would really be able to do that clearly. So because a power of attorney hasn't been established, what we're looking at, if the family is not able to mobilize themselves or organize themselves around providing more care for Mrs. K, then we're going to need to get some kind of legal entity involved. The National Association for Elder Law Attorneys has a list of elder law attorneys throughout the country. It might be good to start in her area to see who might be available to consult with around this situation. Right. It's also possible, due to her finances, that the public guardian, I know guardianship is really always a last resort, and especially a public guardian. I know they do not like to get involved when there is family that could potentially be more involved.
So maybe
but
the son heard that.
Right.
Maybe that would mobilize him.
Right, exactly. Maybe we could get the public guardian to perhaps consult with the case coordinator. Maybe they could be in touch with the family. I do know that they sometimes send out physicians too to do a capacity assessment as well. So all of this is something to explore.
Yeah, it sounds like we have in our resources at each of our Alzheimer's disease assistance centers some information about either doctors that can provide some of these evaluations and might be willing to go to the home setting or make things a little bit easier and amenable to come and do an evaluation. We might have lists of geriatric care managers or how to access that. We might have lists around elder law attorneys. And that might help, if we can provide that information to the group. And it sounds like for the family, they may need some help and support from information from the Alzheimer's Association and the local chapters in their area to get more information about how to handle somebody that might be experiencing Alzheimer's disease and how to be more involved as a family. But I really do think, one of the big messages that I think that's an important learning point is that we just can't depend on the mini-mental. What do you think about that, Darby?
Exactly, absolutely. Well, at the MMSC, and I know that we a lot of times think that 25 to 30 is normal, and it's really important to not just look at the number and to look at how that person is actually functioning at home. and in their daily life. And this person is clearly not functioning in the way that she was in the past,
Right.
and clearly needs some assistance.
Yeah, there's too many signals in this story, even in the initial evaluation, that should be, sending red flags up that we need to intervene a little bit more and get a story and figure out what's going on with capacity at a medical evaluation. Do you think that's enough information for you, Charlene?
I think that's good.
In our second scenario, we'll hear the story of Mr. G. Mr. G is 84 years old and has a diagnosis of Alzheimer's disease. He recently fell and hit his head, ended up in the hospital, and a home health agency made the referral because he was discharging home to live with his wife. His wife is feeling very overwhelmed because he is exhibiting some confusion and some difficult behaviors which are now putting him at risk of losing his services. We'll now listen to the new care coordinator staffing the case with her supervisor, Wyvana.
A call was made to Mr. G's spouse to schedule a home visit to complete a comprehensive assessment. The participant scored a 67 on his DON, but the MMSE couldn't be completed due to his refusal. I attributed the refusal to his recent diagnosis with Alzheimer's. I discussed services available in the program, and a care plan was developed. The services for the care plan included an EHRS and a home care aide. The home care aide would provide a split shift in the morning and the late afternoon to help him with the transfer in and out of his bed. I received a call later that the client had been acting increasingly combative with his care worker. On an evening shift, the client slapped the worker on the head. IHS was put on hold temporarily. I spoke to his daughter, Gloria, who said that she had experienced this with him in the past. She took him to the doctor and his medications were adjusted, and that seemed to put everything at ease for a while. However, she also has an appointment later in the week to speak with a gerontologist and someone who specializes in Alzheimer's. I also placed a call to his home care aide to explain the situation to her, since she had reported the incident when he had slapped her in the head. My questions to you are, do I keep all his home services on hold for a while until after he sees his physician? Or should I have given out different information or reported more on the incident?
Well, I think that we should keep the services on hold for a while, at least until after he's visited with the Alzheimer's specialist. And I think that we should try to get a little bit more information from the daughter and the mom regarding some of the past behaviors that this client has experienced. I also think that maybe we should pair you up with one of our seasoned care coordinators so that you guys can go out there and see if you could see any other different behaviors with this client. What would you think about that?
I think that sounds like a great plan.
I received a call from Mr. G's wife to schedule an appointment for a comprehensive assessment. I arrived at the home with Mr. G and his wife present. I completed the DON and he scored a 67. I began the MMSE and he became very agitated and refused to answer the questions. I stopped and talked about services in general. This relaxed him, and I went back to the MMSE and he scored a 10. During the assessment, his wife revealed that it is very difficult to transfer him in the morning and the evening. He is a one-person assist, but she has a hard time because of her back. Their only daughter tries to help out, but works full-time, and they don't want to burden her. Mr. G's wife is retired, but is feeling overwhelmed because she can never leave him alone. I discussed with her if there were times during the day that his confusion was worse. She said that later in the day he became more disoriented, and she is concerned because he has started to get up in the middle of the night and wander around the house. She's afraid that he will leave the house at night and she won't know. I suggested that she get door alarms. I also suggested that she contact the police department and let them know that he has dementia and give them a current photo just in case. I discussed CCP. She's interested in the emergency button, homemaker service, and adult day service. After discussing the options, she agreed that having a homemaker in the morning and the late afternoon would be the most beneficial. She could still manage laundry and cleaning, but needed help with his personal care. He is approved for a split homemaker schedule, 8 to 10 a.m. and 5 to 7 p.m. Monday through Friday. She'll be touring the local adult day center next week. I questioned whether Mr. G has the capacity to push the emergency button at the appropriate time. It was decided that since he's never alone, that we wouldn't install the emergency button. Mr. G and his wife have about $75,000 in assets. I explained the process of applying for Medicaid, prevention of spousal impoverishment, and I completed the application. I asked Mrs. G if she had thought about what would happen if it became too difficult for her to care for her husband. And I told her that CCP is not able to provide 24-hour care. We discussed hiring a private pay homemaker on the weekends. I gave her a list of agencies. He doesn't have a long-term care insurance policy, but he is a veteran. I suggested that they apply for the VA Aid and Attendance Program, and I referred them to the Veterans Assistance Commission for help. We also discussed nursing home placement, and I gave her a list of nursing homes that have secure dementia units and accept Medicaid. I also gave her a guide on how to choose a nursing home. I told her about the supportive living facilities that have secure dementia units and gave her a listing of those also, but I'm not sure if he'll be appropriate. I suggested that she talk to them.
I would like to commend you on how much detail you were able to get regarding the client. I want to thank you for enduring with the MMSC so that you was able to score him. I think it was also very helpful that you were able to talk with the daughter and get a lot more detail about the past behavior of the client. I do think, though, that we should get more information about his past behaviors. I also think that we should follow up with the daughter regarding what happened when she visited the gerontologist. I think that we would be able to keep the morning services in. However, because they believe that he's sundowning, I think that we should pull out the afternoon service and contact the homemaker agency to make sure that they have did some de-escalation trainings with their homemade, and also to see if this is a regular homemade or if this is a homemade that has been there on a regular basis. I also think that we should contact the Alzheimer's Assistance Center so that we can get some support on how to best handle this client.
We've had some discussions over the phone, and I'm so glad we were able to meet today to talk about this really complicated case that I received from the case coordination unit. You know that I received a call, and I wrote down my notes and sent them to you, and I'm so glad that we're able to sit down and talk about the issues about Mr. G.
Yeah, and thanks, Darby. I mean, for your notes, it was very helpful for us to be, for me at least, to be able to review the notes before we met today. And I would have to say, reviewing these notes, this is probably a very complicated case, but it's probably not uncommon as a case that's been faced by case coordination units around Illinois. And it seems like when I was reviewing it, one of the things I was thinking about as a big theme that might be going on here is around safety. Safety of multiple people involved, and that's what's stopping the services right now, or cutting back the services. And I'm wondering if there's some advice we can give the group around how we can maintain safety and keep the services still going.
Right, that was one of my main concerns, was safety, not only for the caregiver but for the wife. And I've run into this many times, and with my patients is fear for the spouse or the caregiver when the patient gets agitated. And so we need to make sure that they've had de-escalation training, and I wonder what other training they could have and what other tips we could give these caseworkers and the wife.
Right. You know, this person is so impaired.
Right.
I mean, they're pretty advanced in their disease, and from what I understand, they have had a diagnostic evaluation, and the diagnosis is Alzheimer's disease. Is that your sense of the situation?
Yeah, I think there was a report early in the process after the person got discharged from the hospital about Alzheimer's disease being on their record. And it does seem like they have a primary care physician that's been helping to manage their care. But I do wonder, Charlene, I mean, based on your experience, what are the things maybe the case worker can do in that situation where she was trying to change Mr. G, and then the episode happened where he hit her over the head?
Right. So one thing that we would make sure is that the caseworker has been trained to handle and work with patients with dementia, that she knows that if he gets agitated, she should stop whatever procedure she's doing and maybe distract him with some other conversation, have some calming music in the background, something of that nature, so that he doesn't get agitated. And if he proceeds to be agitated with undressing or whatever, just stop. You know, you don't have to finish it. I've had patients that have gone to bed in their clothing. You know, they don't have to get in pajamas every night. Also, I've told spouses that they could get the patient ready for bed at an earlier time. You know, this patient is being put to bed or getting ready for bed between 5 and 7. That's usually when the sundowner sets in. And so maybe if a caseworker came earlier or a caregiver came earlier in the day and got him ready for bed earlier before he got so agitated, they could continue services without medication. On the other hand, sometimes you have to resort to medication.
Yeah, and there may be simple things also that we always have to remind individuals is if you're in a situation that's new to you and you've got somebody that might be erratic in their behavior, depending on the situation, it's just making sure you have an egress out, that
Right.
you don't put yourself in a corner, that you can't escape a situation, and making sure you're in a place that doesn't have objects that somebody can throw or be used as weapons to harm you in any way. Those might be some other simple options we can help teach and encourage the caseworkers to put into place with the home health aide to make sure they're protected.
Right. And just to piggyback on what you were saying, Charlene, about the behavior, I mean, behavior is a form of communication. And yes, it would be very helpful for that the home care person to actually learn some different strategies of how to approach them, and to really understand that you can't be rational and logical with somebody who is so impaired with this disease.
Right.
And
We always say it's like dealing with a 5-year-old. You can't win an argument with them, so don't argue. Don't try to reason with them, because, like you said, you're not going to be able to, because they don't have the capacity to reason.
and if they're getting agitated, to take a break,
Right,
to stop,
right.
yeah, and to come back later at another time.
And it's
Yeah.
definitely something we've always mentioned to caregivers and others is, with the disease, a dementia syndrome caused by something like Alzheimer's disease, we cannot always change the person who has the disease, but we can definitely affect the environment of not only the professional caregivers, but also the family caregivers. So they need to change and understand how to change. But we know that's difficult because people think that this is sort of somebody getting back at them, or they're willfully doing these type of behaviors, when in reality it's sort of the disease that's speaking in its own right. But we just need to look at each case and understand and break it down into why they might be having this issue happen, and then think about ways we can change the environment to make it a little bit better.
Absolutely, and this the caregiver, the wife, is so overwhelmed and stressed, and rightly so. And I'm wondering, I know that there's a daughter, and she's there and is supportive, but I'm wondering if she recognizes that there is more support out there, that the support of the Alzheimer's Association that has support groups throughout the entire state.
Sure.
So,
We do recommend that families contact the Alzheimer's Association. They can get online. There's a helpline. They can go to support groups if they're able to. And most of the support groups, you can take the patient with you if they're able to.
And the other thing we found is somewhat helpful is that the National Institute on Aging, with their Alzheimer's Disease Education and Assistance and Referral Center, ADIR, essentially has put together a manual for caregivers of individuals with dementia due to Alzheimer's disease. That's easy to read, but it goes over some of these behavior concerns and how to handle them. And that might be a good resource that we can maybe suggest that the case coordination units share with their home health aides, and then also with the families, so that they can learn more about sort of what the behaviors are, what to expect, and how to handle some of the better communication around it.
They have a home safety brochure The Alzheimer's Association has a home safety brochure as well. It's the one you're talking about, so that might be something they could, like you said, hand out to the family and to make sure that the care workers are familiar with
yeah,
it.
and I think that's good. And I know that sometimes, as they've mentioned in this case, that talking with their family physician, and there's been some attempts at adjusting the medications, is another important facet. But I think we all have to realize and help to teach each other that the medications right now are not the full answer, and we shouldn't be waiting for necessarily the medications to automatically change the situation. There are no really approved medications for the use in people with dementia to prevent the behavioral symptoms. There are things that we sometimes use off-label to help, but they do have side effects, and we just have to be really careful about their use and warn families about what to expect and how to prevent some of the side effects like falls and increased sleepiness and changes in blood pressure and diabetes potentially. So we just have to use those in sparingly, and in the situation where we just want to make the crisis point lower a little bit and give the family time to build these skills and build a team to help support them with these non-pharmacological interventions.
Yes, and I think I'd like to just compliment the case coordinator, the seasoned one who handled this case, that she really did get very involved in linking the client and family with, especially around financial issues and resources in the community, like the Adult Day Center, the VA. She's really kind of planting the seeds also for possible nursing home placement in the future. Because as this person, as he progresses, it's going to become even more and more difficult for the wife alone to manage his care. And we know how limited the services are through the Department on Aging.
What would be an option for them as a family member to talk with their doctor about, to get maybe another set of eyes and ears in the home to kind of evaluate the behavioral situation?
They're
about
up with the doctor about
the home health
Yes,
options.
absolutely. You know, the home health is sometimes an underutilized service, and Medicare and other insurance reimburses for a visiting nurse, occupational and physical therapy, speech therapy, and social workers to go into the home up under a doctor's order. And I think in this situation, getting a psychiatrically trained nurse would be very beneficial for this family, and perhaps getting maybe all the services, OT, PT, and social work, to go in and do their assessments and see how they might be available, and see what suggestions they have for the family to help maintain this individual's quality of life and the families for as long as possible.
Sure.
The final point to realize is that even for the family physician, and with the expertise in geriatrics and maybe even as an Alzheimer's disease specialist, there are some limitations when you get in these situations where you're using some of these second line agents to try to help somebody, and they're looking at seeing if they can see a geriatric psychiatrist that might be able to help with some options around the medications may be worthwhile if things haven't seemed to be working in the process up till now. They're few and far between, but they're very good once you can get into touch with the right individual. And I think we may have a list of individuals in the area that are geriatric psychiatrists, and maybe that's something we can provide the case coordination unit so that they can share that with the family.
Absolutely.
And I was also concerned about the safety in the home as far as the patient, the wife locking him in the bedroom at night. I thought that was dangerous. If there was a fire, there wouldn't be any way for him to get out. So I suggest maybe putting a high lock on the door to the outside. And I think they had mentioned putting alarms on the doors, so you can just get little bells on the doors, something that wouldn't cost a lot but would alert the wife. Or baby monitors a lot. There's another use for baby monitors, and I know a lot of families have used those in the past, so that she would be aware when he does get up in the night. And then making the home safe by putting up knives, medications, taking the knobs off the stove if he is bothering with any of those things at night.
Great. These are all incredibly good suggestions. And maybe we should just summarize so that I can write an email or call the case coordination unit and give them our recommendations. So let's just maybe go over what those themes are.
So I thought the first big theme we were talking about was around safety, safety of each individual working in this situation. So the safety of the home health aide that's visiting the home and providing services, the safety of the person with the actual condition, Mr. G, and then also the safety of his family and his wife. And I know we had some particular suggestions around each of them and what they could do to make the environment safer. I think there was a second theme was around the behavior as communication.
Right.
Yes. And recognizing that that not to respond in a logical and rational way, but to also understand that if he's particularly agitated or anxious, that someone, a strange person approaching him in a way to try to undress him or change his clothes or do some personal care, that can be very disconcerting to someone who really doesn't understand what's happening.
Right. So
And
making
so-
sure that everyone's educated on ways to approach the
Right, to
patient.
be very calm and to really back off if you find that person is very anxious about what you're trying to do.